All right, I've got 10 o'clock, so we're going to go ahead and get started. All right, so seizures, syncope. Okay, we know what we're talking about here. Seizures and syncope. So, what is a seizure? A sudden onset of random continuing electrical impulses in the brain. So, at some point, some place in the brain, there's an electrical impulse that should not be happening. And what can happen is that it can contain the entire sphere or hemisphere, rather. It can go to one portion of the brain, or it can completely take over the entire brain, causing what we see as the tonic-clonic seizures. We're going to see examples of that in a second. So, the alteration of brain, okay, we know what this is. Epilepsy is a very common cause of seizures, okay, that is its own diagnosis, which is like a subcategory. When someone says, I have epilepsy, okay, that is a cause, it is a root cause of seizures. But there are also other medical conditions that can cause seizures. We're going to go into a whole list of those. Diabetes, fevers, etc., etc., etc. Okay, so when we're talking about the pathophysiology, the why does this happen? In truth, they don't know exactly why seizures occur. They know what is happening, and they can explain that, but they don't know the initial why. Why does this happen? All right, so like I was talking about earlier, when it can include a partial seizure, it just involves one hemisphere of the brain, but it can expand to both hemispheres of the brain. And that's where we're going to get our more severe tonic-clonic or grand mal seizures, as we know them to be called. All right, so the secondary, the provoked seizures, okay, they have some underlying cause. Like we talked about earlier, some of those reasons could be fever, infection, hypoxia. It could be hypoglycemia related. It could be from drugs and alcohol. Okay, those are all reasons that it could be. Another reason that we see seizures are in pregnant women that are hypertensive. What is that called? Pregnant women that are hypertensive. What is that called? Starts with an, well, really it's two words, but really the word I want to talk about starts with an E. Pre-eclamptic. Exactly. They have preeclampsia. When does preeclampsia become eclampsia? When they have a seizure. Okay? Preeclampsia is that hypertension of pregnant women, okay, where we're talking about their systolic blood pressure being consistently over 160. That becomes eclampsia after their first seizure. All right, so common causes like we were talking about, high fever. Those are called febrile seizures. We see those in children. Okay, we see those in children often. But it can also occur in other medical causes like heat stroke. Okay, heat stroke can be another reason that we have a seizure. Non-compliance of seizure medication. Could somebody shut the door, please? Like I said, sepsis, so infection, poisoning, hyperglycemia, TBIs are another reason for seizures, okay, and shock. All right, I'm not going to go through all these reasons, but these are all other reasons, and I just talked about some of them. Hypertension, eclampsia in pregnancy. When does eclampsia, or when does preeclampsia become eclampsia? After the seizure. This kind of goes in line with that high fever, hyperthermia. So someone is hyperthermic. They have an excessively high body temperature. All right, status epilepticus. This is a seizure that lasts more than 30 minutes. Or you have a seizure that has a very minimal, prolonged seizures. It's back to back to back to back seizures. Okay? Generalized motor seizures. When we're talking about the tonic-clonic, and we're going to get in that in a second. All right, so the tonic-clonic seizure. Tonic, what does that mean? That is the tensing of the musculature. That is the tensing of the musculature. The clonic portion of that is the thrashing about of their limbs. Okay? Tonic is the tensing of the musculature. Clonic is the thrashing of the limbs. These used to be called grand mal seizures. We used to call them grand mal seizures. And we're going to get into some specifics about how we as EMTs react to this. Because is there much that we can do for them? No, not really. Not really. Okay. As a paramedic, we can give them, medications like diazepam. That's one that we more often give these guys. But as EMTs, we can't give that. So we just kind of have to treat the symptoms, okay, and just take care of them as best as possible. All right. So this is typically the phases in which these things occur, or stages as they listed here. Aura. What is an aura? Can anybody tell me? A warning, okay? It could be a smell. It could be a sight. It could just be a feeling, a sensory perception by the patient, okay? I don't think I've brought this up before. I have epilepsy, okay, due to repeated traumatic brain injuries. So I have seizures. My aura, okay, is a really unpleasant one. I'm told a lot of people get like fruity smells, like lemons or oranges. Mine is stale cigarettes, okay? Super unpleasant, but it's I know when it's happening. So when that happens, okay, I can alert somebody. Then you have that loss of consciousness, the muscle rigidity, the tonic phase, like we said, the hypertonic phase, and then the clonic phase. This is where we have the convulsions. We are thrashing about. And then postictal. So the postictal phase, they are no longer actively seizing. They're no longer actively seizing, but they are not alert and aware. They may be looking at you. They may be tracking you with their eyes, but they're probably not going to be talking, and they're probably going to be in a really sedate state. All right, so this is just an example of somebody. She puts herself down, so maybe she had an aura. Okay, she identified, I'm about to have a seizure, so she got down on the ground. She has the tonic portion, the tensing up of the muscles, and then the clonic portion where we start to thrash about. And then we have the postictal phase as it ends. All right, tonic-clonic seizures are an emergency, okay? And especially if they go from back-to-back-to-back seizures, that status epilepticus, okay? The repeated follow-on seizures. Sometimes these individuals are not breathing, or they're breathing inadequately while this is happening. So what's one thing you might want to do as soon as they come out of their seizure? Airway, and give them O2. Okay? Airway, give them O2. So an absence seizure, okay, this is called a petit mal. Like I said, the tonic-clonic, we call them grand mals. Absent seizures, what we refer to as petit mals, these are kind of the 1,000-yard stare, that blank expression on their face. It may last a minute, it may last two. They're just kind of out of it for a little bit. Okay, we've all spaced out at some point in time, okay? But you're probably still mildly aware of what's going on. These individuals, they are actually having a seizure. It's called an absent seizure. They do not know what is happening. Myoclonic seizures. Okay, these are brief spasms, brief muscle jerks of the body. They can occur in groups of muscles, and they can occur on both sides of the body. Tonic, we talked about this. The atonic seizure, okay, is the increased muscle tone of the body, all right, the muscle rigidity. And like I talked about earlier, febrile seizures. This is because of a extremely high fever of the patient. We see these in children more often than not, because as our very young infants, okay, and maybe some of our geriatrics, we have difficulty regulating body temperatures. And because of that, their body temperatures spike and they have seizures. Okay, more types of seizures are partial seizures, or maybe focal onset as they're called. The patient knows what's happening. They're awake and aware. They can target a very specific part of the body. For example, it could be an arm or a hand or a leg, and they just completely spasm in that area. So partial seizures, like we talked about, it could be a motor, sensory, autonomic. Okay, if you guys want to look more into this, check out the notes section, because you guys all have access to these, right? Okay. because I'm trying to blaze through these, but these are all super important stuff. Let me kind of get to where some of the more important stuff is. All right, we're going to talk about, okay, treatment. How do we respond and react to these guys? So, one of the first things that you need to do is that if they are sitting upright, okay, and they are having a seizure, let's say they're in a chair, it's happening in class, or maybe it's an office setting, gently get them down to the ground. Gently get them down to the ground. Place something behind their head. Why? Exactly, so they don't have that rapid smacking of the head, because they are going to go in that clonic phase where they are just thrashing about, that convulsions. We don't want them to receive any additional injuries, so we can, in this example, we see some couch cushions. Place that behind their head. Fold up a towel, a blanket, a jacket. If you have nothing else, maybe someone is willing to place their thigh behind their head. Okay, something so that the patient isn't hitting their head against a hard floor. Additionally, you see the EMT in this photo. What is he doing? He's moving the table. He's preventing the patient from hitting anything as they are convulsing. Question, should we hold our patient to prevent them from thrashing about? No, why not? It's going to cause injury, possibly to you and very likely to them. You see sometimes that you'll come up on scenes, like a family member has a seizure. Nobody knows how to react to it, and what they do is that they hold the patient down. Sometimes they now break bones because of this. The patient ends up having broken bones because they're in that tonic-clonic phase, and someone is holding them while it's happening. So not only do you have to deal with the postictal state where they are getting out of their seizure, or maybe that status epilepticus, but now you may have to splint a broken bone. All right, A, B, C, D, okay, that decide transport priority is a load, go, or stay in play, okay, airway, breathing, circulation, check their airway, like we said, check their breathing, and then get them some oxygen. They likely need oxygen because they probably were not breathing while the seizure was happening. Or you get the sonorous sounds. What are those? It's up here in the notes, but you may see that in your National Registry. Sonorous sounds, what are those? Snoring. What causes snoring? The tongue. The tongue relaxing and falling back. If someone is seizing, what might happen? The tongue is going to fall back, okay? So people talk about, oh, he's choking on the tongue. You can't choke on your tongue, okay? Unless you have those individuals that, I can't remember what it's called, directly beneath your tongue that connects it to your maxilla. People will sometimes sever that. What is that called? Somebody look that up for me. It's a wild thing. You see people getting piercings and stuff through there as well. Is it a tiny little bit? All right, somebody look that up. Well, we're going to talk about that in a little bit. But the point is, you can't choke on your tongue. Okay, you might have to suction their airway, okay, because they may have excess secretions. Okay, maybe they bite down on their tongue, okay, and causing bleeding. What's one thing you should never do to a patient that's actively having a seizure? You should not put anything in their mouth, okay, especially your fingers, because if they chomp down, you're not getting it back. All right. The strength that it takes to bite through a baby carrot, okay, is about the how much it takes to bite through a finger. All right, that's not much. Now, somebody's having a seizure, chomp, your finger's gone. All right. All right. So ABCs, we talked about this a second ago. Okay, protect them from any injuries, and then once we are able to, once they're at that postictal state, okay, they're no longer seizing, and they come out of it, and hopefully after some time they're now aware and able to answer questions. We need to start our OPQRST and sample. We need to ask them a lot of questions. Okay, what are some good questions you might want to ask somebody that just had a seizure? What medications you're on? What else? Huh? The P in sample. What is the P in sample? That's an OPQRST. What's the P in sample? Past medical history. Do you have a history of seizures? Probably a pretty big question to ask somebody. All right, so we're going to do a full head-to-toe, that DCAP BTLS assessment of these guys, because we want to make sure that they don't have any additional injuries. Get a full set of vitals, consider the need for ALS. When for sure do you absolutely need ALS on scene? Yes, status epilepticus. Why? Because is there anything we can do to break them out of that seizure? No. ALS, paramedics, they have diazepam. They have other medications that we can give to break them out of that seizure, or hopefully break them out of that seizure. We need ALS. All right, so here's just some examples of medications that we use to treat it. Like I talked about right here, diazepam. Okay, that's something we give. Some of these other ones are medications that patients might take to, bless you, to prevent seizures. So someone might be on a regimen of Klonopin, known as clonazepam. Some other medications you might see, lacosamide, that's a very common one, or lorazepam, Ativan, that's another one. Here's probably the most common one you're going to see. Okay, so when you're doing your write-outs, if you when you are getting your patient's medications, levetiracetam, also known as Keppra. If they have seizures, they're probably on Keppra. Okay, here's just some more. All right, so we talked about this. Signs and symptoms that we may see if someone having a seizure. The aura, again, what is the aura? The warning, okay, the loss of consciousness. Then we go into that tonic-clonic phase. They might bite their tongue, and we might have excess saliva, so we may have to suction their airway when they come out of it. They may lose bowel or bladder control, okay? They may wet themselves or soil themselves. Patient dignity, okay? If that happens, don't make a fuss about it, okay? Just try to get them into the truck as quickly as you can without embarrassing them any further. If they're at home, maybe ask a family member if we can take along a change of clothes for them. Okay, obviously, once they get to the hospital, they're going to be put into a gown, but they're going to want to leave the hospital in something other than their soiled clothing. So that might be something we can talk about. That post-ictal confusion, like I talked about, they may be tracking you with their eyes, but they are still not there. Okay, you got to give it a few minutes. Protect the patient from injury. We talked about this. Maintain the patient's airway. An OPA is not a good idea for these guys. Why? If they go back into a seizure, they're going to probably clamp down. And what's that going to do to their teeth on an OPA? They're probably going to break some teeth. All right, so an NPA is where you're going to want to go for these patients. Suction as needed, okay, ABCs, and then decide on our transport decision. Syncope, what is syncope? That's a fancy word for what? Fainting. Okay, there's a lot of reasons that someone can faint. Okay, there's a lot of reasons that someone can faint. I'm pretty sure it's in here. I haven't looked over this beforehand, but have you guys heard of orthostatic hypotension? All right, I wish that they had brought that up because you're going to see this term again. Orthostatic hypotension. What that means is, actually, I'm going to describe it in a way that's much easier to understand. Have you ever been sitting down and then you rapidly stood up and got dizzy? That is orthostatic hypotension. Now, we're all young, and most of us are very physically fit. I'm not. So I'm the most of us here. I'm not very physically fit. But as we get older, okay, and we don't really maintain that level of physical fitness, let's say our geriatric patients, they stand up too rapidly, they become they have that orthostatic hypotension, they might fall, okay, creating another injury. All right, primary or secondary systems, that's a that's a DCAP BTLS. Okay, we're going to get our history, our OPQRST, and sample. Keep the patient supine. Why? Because they already passed out once. It can happen again. So I don't want them standing up because I want to minimize the possibility of them falling. Because if they fall, what might they hit? Their head. Okay? I don't want to minimize the injury to the head. Let's say someone has a fall and they're on blood thinners. What can happen? They can bleed out. Okay? Especially if they hit their head. So, keep the patient supine. Alright, moving on. Assessing the head for any type of trauma that decap BTLS. This is imperative. If you have someone that you arrive on scene, they say so-and-so passed out, okay, check their head for any signs of trauma. Possible causes. We talked about this a second ago. Epilepsy, okay, so they may be having a seizure. Head injury. Maybe they were hit in the head and then went unconscious. Meningitis. O2 deficiency. They're hypoxic. ODs. Metabolic electrolyte abnormalities. Brain tumors or low blood sugar. What do we call that? Hypoglycemia. Okay, febrile seizures are another cause of syncope. Febrile, so it's a seizure caused by a fever. Check their AVPU, okay? We need to know the difference between seizures and syncope, okay? We just talked about what seizures are. Okay, we have that whole list. They're going to have an aura, well, they more than likely have an aura. Then they go unconscious. Then they have the tonic phase. Then they have the clonic phase. Then they have the postictal phase. All right, that is it when we're talking about syncope and seizures. Any questions?